Let me introduce Felix Leon. He is from the same school as Carlos. And Felix, very nice to meet you. And thank you for joining us today. So Felix will present patient-centered practice in spinal cord injury. Individualized care leads to individualized results.
Great, thank you. So let me just share my screen with you. So just please let me know if you can see my presentation.
Yeah, it works.
Great, great. So greetings everybody. Buenos días a todos. Greetings from Mexico City. So before we start, I would like you to consider the following questions. What is your treatment goals? What are your treatment questions? Or what are you trying to accomplish with your treatment? Maybe it is, what does my patient need? Are you asking yourselves, what does my patient need? Perhaps it could be, what does my patient want? Perhaps even an even more interesting question would be, what my patient wants is actually what he or she needs. And perhaps the biggest question of all is my treatment really helping my patient? Now, in order to answer these questions, I would like to introduce two concepts, the biopsychosocial model of care and the patient-centered model of care. The biopsychosocial model of care tells us that the individual is comprised of three spheres: the biological sphere, the psychological sphere, and the social sphere. So with these three components, the individual perceives themselves and conducts themselves in the world or in their environment. So maybe it is not only the biological aspect, in this case, a spinal cord injury, that is limiting our patients and therefore our treatment goal or our treatment specific training. Maybe it is how the individual perceives themselves, or maybe how he or she conducts themselves in his or her environment. And the patient-centered care encourages an active collaboration and shared decision-making between the patients, their families, and their primary healthcare providers. So with those questions and with these two components, I would like to welcome you to the topic at hand. Patient-centered practice in spinal cord injury. Individualized care leads to individualized results. Today, we will be discussing two patients, two individual stories, along with their individual characteristics, with the rationale behind their treatment protocols, and the results obtained from these treatment protocols. So the first patient I would like to introduce will be nicknamed Rick. Rick is a 43-year-old patient with an injury at the level of C7 and an Asia classification corresponding to A. He has been living with a spinal cord injury for 36 years, ever since 1986. He reports the use of a wheelchair for transports, and as a specific characteristic of him, he has titanium bars between the levels T7 to L2, as we can see here in the picture at the right. Now, while evaluating the patient, while evaluating Rick specifically told us that he had some goals that he wanted to attain, or that he had some specific milestones he wanted to have. Between the milestones were, I want to have easier transfers, I want to improve my upper body strength, I want to have better trunk control, and I don't want to get wind so often. These goals were then translated into rehabilitation goals. The first goal and the second goal being combined into increased upper body push and pull strength. The third one being to increase static and dynamic trunk control. And the fourth one to increase cardiorespiratory fitness. With these rehabilitation goals, the following outcome measures were devised. Upper body strength was measured by maximum repetitions of dips and rows. The reason these two movements were chosen was because these were the movements the patient was most likely to do when transferring from his wheelchair to a normal chair or to his bed or to his bathtub. Cardiorespiratory fitness was evaluated with maximum power output in the arm crank ergometer. And the trunk control was evaluated by time seated with crossed arms, hereafter nicknamed the Pharaoh position. With these outcome measures, the following exercise dosage was proposed. Dips and rows were treated as with a workout type routine and with a pyramid-like scheme, in which Rick did 12 repetitions, 10 repetitions, and finally 8 repetitions done by 3 series. The ergometer was done with a HIIT type regime consisting of a 1 minute maximum effort coupled with 3 minutes of active rest, done by a duration of 10 minutes in total. And trunk control was done with three positions: the Pharaoh position, the hovercraft position, and the snow angels. The Pharaoh position and the hovercraft position was done in an isometric style fashion, while the snow angels were did by a repetition style fashion. Here are a sample of the exercises that were done. With these exercises, Rick's rehabilitation protocol was as follows. He did a 3-day protocol per week for a duration of 1 month. On Mondays, he did deep exercises plus trunk control exercises. On Wednesdays, he did rowing exercises plus trunk control exercises. And on Thursdays, the final day, he did aerobic exercises, the ergometer exercises, plus trunk control exercises. And during these rehabilitation sessions, he received transcutaneous electrical stimulation of between 70 to 80 milliamperes as needed. After the 1 month duration, every outcome measure had increased. Maximum dips and rows increased by 5 repetitions each, from 10 repetitions at baseline to 15 repetitions at 1 month. Cardiovascular fitness increased by a maximum power output of 3 watts, from 8 watts at baseline to 11 watts at the 1 month. Astoundingly, the Pharaoh position increased to 27 seconds, taking into account that at baseline, the patient couldn't even do the position, meaning 0 seconds. We had the opportunity to reevaluate Rick after a 1 month of rehabilitation, meaning that we had measures of 1 month and 2 months. After 1 month of rehabilitation, only the trunk control remained, and although it wasn't at 27 seconds as the first month, he sustained the static control at the Pharaoh position for 18 seconds. Now, Rick didn't increase in objective measures. He also increased in subjective measures, such as many reports in which he or his family told us that they were observing results. A special characteristic or a special occasion occurred on a rehabilitation session in which he told us that during a family holiday, he fell from his chair and was stuck between 2 door frames. Without being able to call for help, he managed to pull himself up using only one hand, pushing off the ground, while the other was pulling from his chair. He stated that he didn't thought he could do that. And he also stated that should he have failed, he would have seriously injured himself. So as we can see, not only objective results were reported, also subjective reports were reported. The second patient I would like you to introduce is Morty, will be nicknamed Morty. Morty is a 45-year-old male with an Asia classification corresponding of A. He also reports the use of a wheelchair for mobility. And as a special characteristic of him, he has two spinal cord injuries. The first one sustained in 1998 at the level of C7, and the second one acquired in 2014 at the level of T9 and T10. As we can see in the picture, this second spinal cord injury completely severed the spine. While evaluating Morty, he didn't express any specific rehabilitation goals. But while evaluating objectively the Faraday position, he showed poor static trunk control. So the rehabilitation goals were to increase static and dynamic trunk control. With him, the rehabilitation goals were only to increase trunk control, as he had excellent upper body movement and upper body strength. So we only focused on trunk control. The exercises that we did was the Faraday position, the hovercraft position, the snow angels, plus two other movements that Rick didn't do: the Superman position and the boxer movements. The Faraday position, the hovercraft position, and Superman position were done in an isometric style fashion, while the snow angels and the boxer were done by a repetition style fashion. And after 1 month, 0.5 kilogram weights were added to each arm to add difficulty, as expressed by the patient. I will show you a demonstration of the exercises that were done. As we only evaluated these exercises done to maximum isometric hold and maximum repetition were also used as an evaluation. So his weekly rehabilitation plan consisted of only 1 day per week. On Fridays, he did trunk control exercises done 3 times during the rehabilitation session. And this plan was done for a duration of 2 months with an electrical stimulation, transcutaneous electrical stimulation, to 70 to 75 milliamperes as needed. After the 1 month mark, every movement had increased. The Faraday position, hovercraft position, and Superman position increased by well over 1 minute in isometric fashion. And the snow angels and the boxer movements increased to 20 repetitions on both sides, meaning left arm and right arm. After the 2 months mark, the Faraday position, hovercraft position, and Superman position remain at 1 minute. And the snow angels and boxer movements remain the same at 20 repetitions on both sides, again, meaning left and right. Specifically and subjectively, at the 2 months mark, the patient stated while evaluating him, "I can stay in this position or do this movement for well over half an hour. So we might as well get over it." Meaning that the issue at hand was not whether if he could do the exercises. Subjectively, he was getting bored while doing the exercises. Another interesting thing started to happen. Since evaluating Morty, he stated that he had pain in his left scapula due to an awkward arm position sustained in order to maintain balance while working. During the rehabilitation protocol, he stated that the pain had been decreased during the whole rehabilitation protocol, meaning he had better trunk control and no longer was adopting this awkward position in order to maintain trunk balance while he was working. Morty also reported subjective outcome measures, but this time they were reported by his partner. She stated that normally during a night out, he usually pours her a drink and offers her the drink while bending to one side and using his elbow in order to maintain balance. She stated that during the last time they went out, he poured her a drink and offered it to her while standing up, while completely standing straight without support. When she pointed out this to him, he told her that he didn't even notice it. So several clinical insights can be derived from these two stories. The first one being that improvement was achieved regardless of patient characteristics, such as Morty's double spinal cord injury and Rick's titanium bars, along with the time after injury of both Rick and Morty. The second is that improvement was achieved despite relatively low frequency of rehabilitation sessions. As stated previously in other talks, we are aware that normally these rehabilitation protocols consist of 5 days per week. However, and as stated by my colleague, Dr. Cuellar, and in a true clinical setting, this is almost nearly impossible, mainly due to transportation and logistics problems with the patients and with the rehabilitation centers. Both Rick and Morty achieved objective and subjective results with a relatively low frequency, with 3 sessions per week and 1 session per week, respectively. And last but not least, shared decision-making leads to better patient outcomes. Talk to your patients. Listen to them. Ask them what they want, what their goals are, and how you can help them achieve them. What your patient wants may not be what they need, and what they need may not be what they want. It is your job to help them figure out which is which. So, as a conclusion, I would like to thank my collaborators, mainly Dr. Cuellar and the whole rehabilitation team behind my institution. Specific thanks to the rehabilitation team. Without their help, none of this could have been possible. And special thanks to the participants and their families for the willingness and openness to participate in this study. That would be everything by my part. Thank you very much.
Thank you so much for your talk, Felix. Thank you. It was a really great story. Colleagues, please, if any have any questions to Felix.
Could you tell me, please, so you have very specific tasks and trainings. How do you explore it? How did you find that, especially particularly this type of trainings leads to better outcomes?
By experimentation and asking the patient what they want. So experimentation, the protocol started on 1 month, but in reality, maybe 2 or 3 weeks were done prior to the commencement of the protocol in order to test what the patients can do and what they want to do. As many of you maybe have noticed, it is especially difficult to test in this type of patients what they can actually do. So it was trial and error in order to see what they could do. And along with these trial and error times, we spent a specific time in just talking to the patient and asking them what they want, how their daily lives went on, what they did for a job, what they needed to do to do in the work environment, in the house environment, if they drove to the rehabilitation center or to the university, if someone else drove them to the university. So in order to come up with these exercises, it was a mixture of just talking to the patient to see what they can do, to see what might work for them, and that would be my answer. Mainly talk to the patients and ask them, just like really in a normal conversation. just ask, just talk to them.
Thank you. And could you tell me, please, how many specialists works with one patient?
So in every session, we try to have at least 2 physical therapists and 1 engineer, in this case being Dr. Cuellar. Dr. Cuellar operates the special equipment, while 2 physical therapists operate with the patient, specifically to help to guide the exercises, and the other to watch over the patient. We are aware of the capabilities of our patients, meaning if they lose strong control or strong balance, they would mainly fall, but they can catch themselves. So we try to have at least 2 physical therapists per patient, and if we're training another physical therapist in order to take over another patient, maybe 3 physical therapists per patient. On one occasion, we had even 5 physical therapists. So, but mainly 2 per patient.
Thank you.
Felix, may I ask you just one question? So I wonder your thoughts on potential, like from what you see so far with these subjects, and being physician in rehab, right? So how do you see optimal integration of this approach with non-invasive stimulation in clinical practice? From your standpoint, again, being physician in Mexico, like with current protocols, where you see the best implementation? Would it be a combination of inpatient, outpatient, and home therapy, or something you would be focusing primarily in a hospital or outpatient? Like just your overall thoughts.
So maybe I would explore maybe lowering the frequency of rehabilitation sessions, specifically electrical stimulation sessions, to maybe 3 times per week or maybe 1 time per week. We must remember that we're working with patients, with human beings, and not with only numbers or charts. These human beings have lives of their own, goals of their own, inspirations of their own, and fears of their own. So maybe they don't want to spend a lot of time at the clinic, and they want to spend time outside of the clinic, actually enjoying their lives. So I would explore maybe lower frequencies of rehabilitation sessions coupled with a home exercise program. The really key important thing was that the patients use the rehabilitation results in their homes. So what I say to my patients is, here in rehabilitation, we are just stimulating, but the real work or the real bulk of the results will be done by you at your home. So please don't just stay at your bed. So so for future clinical or research opportunities, I would say lowering the frequency of the sessions, and give the patients a home exercise program.
Awesome. Thank you. Thank you so much for your thoughts and for great presentation. So colleagues, please, if any other questions. Well, so if no questions, I think it was our last talk for today, right?
Unfortunately, Dr. Fatihova have patients, and she can't join us, but we can watch the video of Dr. Pritam.
Awesome. Thank you.